Hello everyone, my name is Lucy and on behalf of the organisers Oliver Kinross, I'd like to welcome you all to the third session taking place at Midwest Build Week Online. I'd like to take this opportunity to also thank all of our sponsors involved in this event, but with a special mention to DuPont Advanced Materials, our sponsor for this session. We're going to have a short presentation from Mike Demko from DuPont Advanced Materials, followed by another short presentation by Mai-Britt Beldam from Saint-Gobain Ecofin Group. Over to you, Mike.
All right, thank you. If I could have control to share my screen. Wonderful, thank you very much. All right, good afternoon, everyone, and thank you for attending this session. So my name is Mike Demko. I'm Application Development Leader for DuPont Tedlar, and what I'll be talking about to begin this session is surface protection in a healthcare environment. So to motivate this talk, what I'd like us to do is to consider a room in a healthcare facility. And what I have pictured here is a patient room. And we'll ask the question, who visits this room? Now, it's not a very difficult question. We can come up with a fairly extensive list of people who visit this room. Of course, there's a patient who lives in this room and is recovering from some kind of an issue or ailment. They have their care team of doctors and nurses who are constantly coming in and out to provide tests and treatments. In normal times when COVID-19 is not around, we have family and friends that can come to visit us in the hospitals. There's a catering staff who brings in food 3 times a day and comes in 3 times a day to take the trays away. The janitorial staff keeping the facilities nice and clean, and the maintenance staff keeping things in working order. And as we consider this list of who's visiting this room, we very quickly realize that even a quiet, out-of-the-way patient room is actually a high-traffic area. And just about every surface in this room is a high-touch surface. So there are some additional visitors to this room. There's bacteria, viruses, fungi, and other pathogens. Now, the reason that we care about pathogens is because of healthcare-acquired infections. And these are defined as an illness acquired while being treated for another issue at a healthcare or hospital facility. And of course, if you're recovering from something, this is really the last thing that you want in your treatment plan. And this can come in a variety of forms. There's bacterial, viral, or fungal infections. And some of the infections that are of most concern to healthcare facilities are shown at the right. And if you examine this list, what you'll find is that there's some that are resistant to antibiotics or are multi-drug resistance, and some that are quite lethal. Now, what's surprising is healthcare-acquired infections can affect between 3.5% and 12% of all patients in developed countries. And here in the United States, that number is around 4.5%. The cost associated with this, the human cost, is tens of thousands of deaths each year, and the financial cost is billions of dollars each year as healthcare facilities have to treat patients for the symptoms that they developed inside of their facility. What's additionally surprising is, according to the World Health Organization, healthcare acquired infections will surpass cancer as the #1 killer in 2050. So how do facilities manage healthcare acquired infections? Well, the solution is cleaning and disinfecting. So cleaning is the process of removing dirt, debris, and organic matter from a surface to restore the original surface aesthetic. And it's important not only for making a patient feel like they're in a clean, safe environment, but also because soiling can impede the direct contact between a disinfectant and a surface, or that debris can inactivate the germicidal properties or mode of action of several of the disinfectants that are commonly used. Now, it's important to realize that cleaning itself does not kill or destroy pathogens. And in fact, cleaning can take those pathogens and spread them around your facility if not done correctly. So to kill or destroy pathogens, you need to disinfect. And this is typically done with a variety of things. Most commonly, chemical disinfectants like quaternary ammonium, alcohol, bleach, hydrogen peroxide, acid, but there also can be UV light at 254 nanometers. You have steam treatment or chemical vapor treatment like vaporized hydrogen peroxide. Now, the way that you disinfect a healthcare facility really depends on what it is you're trying to manage. There are certain pathogens which are very difficult to kill, like bacterial spores, mycobacteria, non-lipid viruses, fungi. These all require very harsh disinfectant strategies. So you could use peroxyacetic acid, hydrogen peroxide, hypochlorites. There are other pathogens that are actually rather easy to kill, like lipid viruses, bacteria. These you can manage with alcohol-based or quaternary ammoniums. There are also supplemental no-touch disinfections like UVC light, hydrogen peroxide vapor, steam, that tend to be more broad-based, but they're more difficult to use, so they tend to be used in, for example, terminal cleaning of a room. But what's important to realize is there's no silver bullet for disinfecting surfaces. Every pathogen requires a different treatment. And the disinfectant strategy that you use is a balance of the risk of the pathogen in your facility, the disinfectant toxicity to your patients and your staff, and the risk of damaging the materials in your facility. So just to give an example, this is for normal cleaning and disinfection for COVID-19. And this is taken from the World Health Organization recommendations. So they are recommending chemical disinfectants like 70 to 90% ethanol, chlorine-based products like hypochlorite, hydrogen peroxide for a minimum of 1 minute of contact time. They also, so the frequency of this cleaning is also somewhat surprising. So hallways and corridors, screening and triage are to be cleaned twice daily. Inpatient rooms 3 times daily, and outpatient rooms after each and every patient. Now, the World Health Organization also suggests that you can use supplemental disinfections like UV irradiation or vaporized hydrogen peroxide for terminal cleaning of a room. Now, the question to ask here is, can the materials in your facility sustain this kind of abuse? And this is a great time to introduce DuPont Tedlar. So Tedlar is a brand name for a polyvinyl fluoride film. And the chemical structure for polyvinyl fluoride is shown in the bottom right of the screen. So it's a linear carbon chain that's saturated with hydrogen, and 1 in 4 hydrogens is replaced with a fluorine atom. And that fluorine atom is very electronegative. So what it tends to do is pull electrons towards itself, and it strengthens all of the bonds in that polymer. And what you're left with is a very durable polymer material that is able to withstand very harsh environments. For this fluoropolymer, it makes it easy to clean, it resists staining, and it withstands even the harshest chemicals and disinfectants. In fact, there are no known solvents to this material at room temperature, so it has unparalleled chemical resistance. So the Tedlar film is it's a thin film, a thin polymer film, and it's typically used on the outside of other materials to protect surfaces. So for an example, I could use a PVF film with an adhesive on a printed substrate. I can laminate those together, emboss it to make a really nice DuPont Tedlar wall covering. Or what I can do is take the film and laminate it on a substrate to thermoform it, or take the film and vacuum form it around an existing substrate to make a 3-dimensional part like furniture or cabinetry. The value for using Tedlar in healthcare, first off, it's easy to clean. So it's a fluoropolymer, and even if you have the most intense staining agents sitting on the surface for more than 24 hours, usually you can clean it off just by wiping, and for sure you can clean it off with harsher cleaners. So long-term protection, the Tedlar has unparalleled chemical resistance. So you can use it with a variety of strong cleaners and disinfectants. Pretty much anything you'd find in a healthcare facility. Bleach, alcohols, ketones, strong acids, strong bases, whatever you throw at it, the Tedlar is going to resist it. For UV light, Since PVF does not absorb any UV radiation, it also is very resistant to degrading in UV light. So you can use it with UVC sterilization and maintain a very low color change. So protect your aesthetics for a long period of time. For mold and bacteria resistant, Tedlar is naturally flexible. So we don't add any processing aids or additives that would provide nutrients for mold or bacteria growth. And we've tested this in a variety of external labs to prove that the film does not contain nutritive components for bacteria or fungi. The material is also flame resistant, so it's non-flammable and has low smoke toxicity, and for that reason, it's been used extensively in aircraft interiors. Versatile design, PVF is naturally transparent, so you can use it as an exterior glazing on a variety of different aesthetics. And that color will be stable even when it's used with these harsh chemicals and in harsh environments. And finally, indoor air quality. Our DuPont Tedlar wall covering is GreenGuard Gold certified for both VOC and mold resistance. And what we've also found is Tedlar film, when applied to other materials, can actually act as a barrier to VOCs and slow their release and make materials perform better in some of these GreenGuard or other indoor air quality tests. Now that's a lot of claims I just made. But it's important to note that our claims are backed with extensive testing. So for example, for cleaning and stain resistance, we've listed the worst of the worst that you'd find in a healthcare facility. And we've tested our films and laminates by applying these staining agents to the surface, letting them sit for 24 hours, and verifying that we can completely remove the stain with no trace and no ghosting after 24 hours. For mold, mildew, and bacteria, we've tested these films with external labs to show that they do not contain nutritive components to support growth for either bacteria or fungi. And then for chemical resistance, again, PVF has unparalleled chemical resistance, but just to be sure, we tested with all of the most common solvents and cleaners and disinfectants that you'd find around a healthcare facility to verify that the films are undamaged, even after extensive cleaning. And it's really for that reason that Tedlar films have been used in healthcare facilities for over 30 years. And you can find our products in wall covering, on the ceilings, in ceiling tiles, doors, windows, furniture, cabinetry, and even flooring. Really any application that needs upgraded chemical resistance, cleanability, and durability can benefit from having DuPont Tedlar on the surface. So thank you very much for your attention. At this point, I'd like to turn it over to Mai-Britt, who will be talking a little bit about acoustics in healthcare.
Thank you, Michael, for this very, very important presentation on healthcare-acquired infections, cleanability, and disinfection. I'll just share my screen here. Yeah. Here it goes. My name is Mai-Britt Beldam, and I'm sitting in Copenhagen right now. I work for a company that is based in Sweden that is called Acoustic. And together with Tedlar, we have had the opportunity to develop an acoustic product that is made with Tedlar film. So it's really highly hygienic, and it's also sound absorbing. Acoustic has a brand promise, which is a sound effect on people. And this is the backbone of what we do. We really care about how people react to their surroundings, how we are affected by our buildings. And we do that by providing the world with acoustic tiles for ceilings and wall systems. And today they are made of 70% of recycled glass. For thousands of years, we have developed for the outdoors. And this is our optimum acoustic situation. This is what we are meant to react to. Our hearing out here works perfectly. We will react to fear. We will react to a hostile enemy approaching us. The sound will pass our ears once, and then it's gone. Out here, we have no hard surfaces. the sound will simply just propagate away once it hit our ears. So this environment is what we have in mind when we designed for the eye, the ear, and the mind. Unfortunately, this is not what it looks like acoustically when we come into a healthcare situation. Winston Churchill once said, "We shape our buildings and thereafter they shape us." And this is what we're shaped by when we are sick, when we're in a hospital. Just think about the alarms. Just think about the sounds of the ventilator. Just think about the conversations that are not relevant to you. And then think about that you're sick. You're already out of your comfort zone. You cannot choose anything for yourself. And you're stressed out by an environment that is not your natural environment. We have studies from Europe saying that in the ICU, you sleep in average 6 minutes before you wake up. In a 24-hour period of time, that's 167 times you wake up. And that is not good for recovery or cure or care. Also, the staff will be overwhelmed by all the sounds during the day. This is not an age test, but maybe some of you remember this game, this video game. And this actually mimics what happens with sound waves when they are not absorbed in a hospital. They will simply just bounce back and forth, and they will build up, and you will have bad speech clarity, you will have long reverberation time, and really high sound pressure levels. This is what it looks like if we forget about room acoustics and we forget about that sound absorbing surfaces are equally important. This simple solution with an acoustic ceiling, which mimics the acoustic sky outside, and acoustic wall panels that mimic the open width, this is our optimum. If we can just make the sound environment inside like the outside, where the sound can just disappear when it hits our ears, then it's good for us. I will end my small presentation with this quote. I've said many times that the person who designs and operates your building has a greater impact on your health than your doctor. And I would like to say that we have a lot of research showing that we have an increase in medication intake in facilities where the sound and acoustics are not sufficient. We see more mistakes in the operation rooms when the sound environments are bad. And we see a lot of issues in regards to stress and burnout with staff when the sound environments are bad. So if I can say only one thing today, it is to think about the acoustics. We can actually combine it with hygienic features today. Thank you. I would like to pass over to Jenny now.
So good afternoon for those of you who are in the US, and I think that everybody is here during the afternoon. Welcome to this session. We are going to head into the panel as soon as we do some introductions. So I just want to comment that I appreciate the Pong reference. I believe that's dating myself, but I think that's what that video game was, and I'm familiar. So I'm going to start off by kicking off the introductions. I have the pleasure to introduce Paul Whitson, if you can show yourself. Paul is the Senior Principal and Regional Healthcare Leader at HOK Design and Engineering. He is representing among this panel the architect's voice for healthcare planning and design. He's coming to us from St. Louis, Missouri, and he hails from his alma mater, Texas A&M University. So go Aggies. Paul, if you, before you introduce our next panelist, can you share with us what your favorite show to binge watch has been during COVID?
After all, I go back to old school Law and Order to get some relief from all the other binge watching, because that I don't really have to pay that much attention to. But I get the pleasure of introducing Margi Kaminski, who is a Principal and Director of Health Interiors at CannonDesign. Margi is representing the design voice from the healthcare interiors perspective and is broadcasting from Chicagoland. She hails from the Harrington College of Design, and we'd love to know what your favorite show to binge watch is.
So Paul, I've enjoyed watching Emily in Paris. It brought me back to the wonderful trip we took to Paris just before the pandemic. So today I'm introducing Mike Demko, who you heard from earlier. He is a materials specialist who serves as an application development group leader at DuPont Advanced Materials. And Mike is representing the healthcare research and development voice from the product perspective, particularly Tedlar PVF films, and is joining us from Wilmington, Delaware. I really appreciated your presentation. It was very good. Mike hails from Case Western Reserve University. Go Spartans. So Mike, what is your favorite show to binge watch?
So a show that I recently just finished was The Queen's Gambit, and it was my wife's suggestion. And I went in, I will admit I was a bit pessimistic, but I ended up really enjoying it. So it's a good recommendation. So it's my pleasure to introduce Mai-Britt Beldam, who you also heard from earlier. So Mai-Britt is the global concept developer for healthcare at Saint-Gobain Ecofon and is joining us from Copenhagen, Denmark. She represents the consultant and vendor voice for healthcare room acoustics. And Mai-Britt hails from University of Southern Denmark. And I just learned today that they don't have mascots in Europe. So a fun fact about that university, the main campus is nicknamed the Rustenborg, which roughly translates
I have some connection issues. I've just tried to turn off my camera for me.
And Mai-Britt, what's your favorite show to binge watch?
So we might actually have a few connection issues with Mai-Britt. So I can share that she told us that she is watching Bling Empire, which is a homework item for me because I was not familiar. But Mai-Britt was going to introduce me, so I will introduce myself. I am Jenny Hahn. I am playing two roles today as both speaker and moderator. So I want to just ground everybody for that. So if I speak a lot, that's because I'm supposed to, and I'm not staying in my lane as moderator. But we also will be sort of self-moderating this panel, so you'll see that. But my title is Director of Design Integration for the Boldt Company's modular program. And I am joining you from lovely Chicago, and you will see the L train pass by me on occasion. I am a licensed architect, and I represent the healthcare design voice with the twist of fabrication for modular. My alma mater is Cornell University, so go Big Red, the Big Red Bears. And thanks to Parasite, my husband has embraced fully subtitles. So we recently binge watched a Norwegian crime series called Borderliner. It's very good, so I would recommend that. So as we try to get Mai-Britt back on, we'll just go ahead and introduce what we're going to be focusing on in this session. We have been asked to talk about new trends in healthcare design and facilities and interiors. As we know, in the normal circumstance, we would have some usual suspects, but I think that it's suffice it to say that we can't really think about trends without understanding the impact of COVID. So you are not going to have relief from COVID during this call, but we will share some insights at the end about what is next, the next chapter after COVID. So to ground us, some of the trends that we've been talking about in the past few years have been the Affordable Care Act in the US and its impact on moving out to communities, health systems, mergers and acquisitions, technology like telehealth and telemedicine. Shockingly, we thought that it was not super possible that fast, and it's happened very quickly. But other things like behavioral health and physician burnout, those are going to be some high-level topics. Each of these topics can be discussed for hours, so we're going to keep it very high level. So the common theme will be in sort of with COVID, but we're going to try to expand beyond that. We have sort of bucketed the topic into 3 or 4 different swim lanes. So first, it's going to be talking about how COVID has exposed some existing cracks in our healthcare system, things that we kind of knew about, but sort of really revealing some ugly heads that we were suspecting were there. It's really shown us how we've had to shift gears in how we use space and how we deliver construction. Also how we begin to really think about wildly designing around flexibility. And then we'll share some parting thoughts about how we can refocus on things that we may have been neglecting, or how we're going to take some of these lessons learned from COVID. So I want to just remind the audience that you can share your questions as we go along in the chat. Our friends who are helping to facilitate this webinar are going to be looking through and sharing those with the panelists so that we can keep an eye on them. But we will be really having a focused discussion at the end for our Q&A session. So let's get started. So the first bucket that we were talking about, where COVID has really shown some of our weaknesses in our healthcare system, a lot of things that we've been trying to address, but now we've been sort of forced to address. Margi, can you share with us an initiative in Chicago that you're aware of that has been already looking into this?
I sure can, Jenny. There have been some really cool initiatives happening in the city and the greater metropolitan area, but one in particular is the West Side United on the west side of Chicago. And it initiated with 3 health systems: Rush University Medical Center, Cook County Health and Hospital System, and the University of Illinois Hospital, coming together to talk about how they can really impact the community. And they expanded this to a broader group of health systems, health providers, and their goal was to help everyone in this geographic area to attain equal access to the building blocks of good health. So they took this really highly integrated approach and engaged the business community, education, and housing development to create strategies to positively impact the lives of people in this community.
So I think it's important to say that some of the reason why that began was because as Rush was doing their anchor mission study, they realized that the health life expectancy 3 neighborhoods to the west of the core of downtown had a 14-year difference. That's one thing. That's about 6 miles going west. But as you go south, there's a 9-mile difference, and probably, I don't know, about 5 neighborhoods south, there's a 30-year difference. So that is shocking. Now that we have that data, what are we going to do with it? So it's important to note that it's a multidisciplinary approach, and I think that's sort of become kind of a theme during COVID as well. But I'd like to now turn to Paul to talk about how COVID and sort of the general trend of affordable care has stretched out to the communities and how telemedicine has impacted that.
Thank you. It's a really poignant topic lately, and we have witnessed that telemedicine has been adopted a lot more quickly than anyone had originally anticipated because of COVID. The HIPAA rules got relaxed. The Medicare and Medicaid rules got relaxed, so that those kinds of visits could happen more easily, just to protect people. But we also have been looking at this for a while in the context of larger healthcare institutions and how they reach out to their communities. And so we had recently been working on a strategic land use plan for an academic health center here in the Midwest. And we had gotten to the point where we're ready to place some buildings, and they recognized this started before COVID and got paused a couple times because of COVID. And we got to some ideas about some solutions, and they realized that they needed to go back and look at their whole ambulatory care enterprise because of the fact that they may not need to see as many patients in brick and mortar settings. That's something that's going to affect the way that we do planning for their campuses going forward. And if anybody subscribes to the advisory board, there was just a notice that came out. They're already starting to look into this from a conceptual and strategic way. So this is something that's going to continue to be a part of the way that we interact with our healthcare clients.
And I think that what you mentioned is in fact like a quick pivoting that we've had to become much more agile during this environment. I think that's going to continue. I think that it also points to the fact that we're thinking about healthcare a little bit differently, or that was happening before, and now it's really expanding when it comes to, we've been focusing on wellness and preventative care, a refocus on behavioral health. What are the social determinants of health, where we have food deserts and what I like to say trauma islands that I'm trying to coin myself. And so the fact that we're saying that healthcare is not just how you deliver care in a brick and mortar environment, in a hospital, in a clinic, but there are so many other factors that are impacting our health. Marge, you were talking about the impact of behavioral health and how COVID has played a part in that. Can you expound on that?
Yeah, well, I think too, the other thing that I wanted to talk about was the providers. And, you know, when you stop to consider, I mean, we've all seen the images on the news of just exhausted doctors and nurses and just all those caregivers who are working longer shifts and double shifts to cover for those coworkers who are getting sick. So, you know, the question needs to be asked, how do we provide care for the caregivers? So, you know, we're working on some staff and provider lounges right now. It's really becoming a thing that our clients are wanting to address sooner than later, because they see that their staff is exhausted and they need some respite. And the staff lounge of pre-COVID is a little different than the staff lounge of COVID times. And so, you know, we need to give people a little bit more personal space, and it goes beyond just 6 feet. You know, people need some private space. And so in provider lounges, we're looking at that. We're looking at providing some communal and some private space, so that they have a place to refresh during these long shifts and the intense stress that they're under.
And space is a very contested issue amongst providers, so that's probably somewhat of a tall order. And I believe that another dynamic of COVID is that, you know, we talk about our healthcare heroes, and they're not just the doctors and the nurses, they're also all of our support services who are in those spaces, especially, you know, with our friends talking about hygiene and cleanliness. We have EVS and transport, and the list goes on and on. So I know that healthcare systems have sort of created a rallying support around those operationally, and which I hope to continue past COVID. But it's really about wellness, and that's a common theme that has been really looked at for some years now. Affordable Care Act started in 2010. So Paul, can you talk about some of the things that you're seeing about wellness and how we design around that?
Sure. We recently have spent a good deal of time designing these so-called hybrid facilities. For the University of Colorado in Colorado Springs, we did a sports medicine and performance center that actually included clinical space and training space and research space to really begin to develop an attitude towards wellness, where exercise is medicine. And the idea is that not only would the patients get treated in the facility, but the researchers and the educators would be part of it and start to really learn how to work in a team, just like the team members do. And there's the way that the excuse me for a second, the way that the providers can learn from high performance athletes. So they start to discover what makes them tick, and how do we push that out to other people, patients, and others otherwise. There's a great deal of opportunity with a bunch of different kinds of patient types, whether it's a professional athlete or a weekend warrior. But having all of that happen together in a space that's not just a clinical space allows you to start to really understand the way that that people can stay well before they have to get into the kind of episodic care condition.
Right.
So, I mean, we're talking about space, but we're also talking about the design process and how to engage in, more evidence-based design, let's say, in a very active way, using sort of, I would love to do more research on like athletes and that kind of thing. It's very inspiring.
Well,
so
we
Michael,
have.
Yep.
I'm sorry. We have the advantage of having a whole sports and rec group as part of our firm, and so I share time with those guys, and we've worked together on a number of facilities, from the Bears training facility to this one recently, to really start to understand how we can learn those lessons from the sports world to start to apply not only in the healthcare environment, but also, do we think about stadiums as places to help deal with mass pandemics in the future, and how that would be effective. So it's more than just the healthcare construction. It reaches out to the rest of the community, which I think is a lot of what Margie was talking about. And so I think that's something that continues to be a priority.
Yeah.
And that really sort of starts to speak to some agility in using space. I mean, we've been shifting things around just to make sure that we can have space, like for vaccinations. I mean, we're going to be probably engaging some of those stadiums and concert venues and that kind of thing, so that we can get these vaccines out. But I wanted to shift gears a little bit. Michael had a question about that had to do with space use. Go ahead, Mike.
Yeah, so a general question for everyone on the panel is, as we think about COVID and coming out of COVID, how have the usage needs and design parameters changed for the future healthcare facility? And I figured everyone on this panel probably has something to contribute, so maybe we'd go around and all contribute to that. So Margie, would you like to start?
Sure, I can start. I think I'll take waiting rooms. Well, waiting rooms, or lack thereof, I mean, that has significantly changed during the time of COVID. For some, your waiting room is actually your car when you think about it, and it becomes the actual waiting room in the facility is just a pass-through. But for the waiting rooms that we have gone into, the obvious is seeing the seating 6 feet apart. But think about it. The people who are working there also want to be protected, and we've been seeing a lot of requests coming in for protection in front of the reception desk, or the nurse station, and which is really a huge shift compared to everything in the past probably 5-10 years has been all about opening up the space and having more transparency and more physical connection, because it created a better experience. But the fact of the matter is we're actually swinging that pendulum in the complete opposite direction for protection. And so, not to mention, what is the experience like for the person on the other side of that plexiglass or glass panel? And so, it's a lot of things to consider, but it has definitely impacted the waiting space, and it'll be interesting to see how those waiting spaces will transition. I know some say they will go away. I don't know about that. I have a 90-year-old mother who likes to get to her appointments a half hour early, despite whatever anybody says. And so, for some, they do want to have that waiting space, and so we'll see what happens as time goes on.
So Margie,
Paul,
I think
go ahead.
Point before you go to Paul, that in some cases we can't just assume that people can wait in their car or are willing to, but so people sometimes come by bus or by walking, and what are we doing with those folks? So.
Right.
But perhaps we can start using administrative spaces and expanding the waiting room areas. I think Paul might have some thoughts on that. Are you with us, Paul? Okay, you're muted.
There we are. No, I'm back.
Okay, great.
I'm unmuted now, I hope. Happens. We've been looking at in the same strategic land use plan that I talked about earlier. We've also been looking at the administration spaces, particularly the spaces that don't face patients, particularly those folks that are doing things that are vital to the hospital, but don't necessarily need to be co-located with clinical spaces or research spaces. And to try and intensify the really effective kind of space on campus that's dedicated to patients and to learning and to doing research, and looking at other locations, whether it's people working remotely from home or from smaller offices that are pushed out into the community. Certainly one of the biggest costs in healthcare construction is the real estate itself. And to be given over, large chunks of space to administrative functions and storage of data in the main part of the campus or the critical care sites doesn't make a lot of sense. Hasn't made a lot of sense for a long time, but now it really we have the opportunity to break the paradigm and start to look at how we push some of those folks into space that's very comfortable for them, but don't take away from the clinical mission and from the research mission. So because those things are what really help patients get better, and that's why we're going to look at spending more time to define what goes on and what doesn't go on in a hospital campus.
So I'll contribute a little bit to this. So from a materials point of view, I think there's two trends that COVID has brought about. And the first trend is disinfectants becoming a heck of a lot more prominent. And this includes first official disinfectants, right? So healthcare systems are more thoroughly cleaning their facilities and disinfecting. They're disinfecting more spaces. So now they're going to be going in and disinfecting the healthcare providers' spaces more often rather than just the public spaces. There's more hand sanitizer stations that are being used. People are actually using them now. They were always there.
Yeah.
But then there's also unofficial disinfection. So we have people bringing in their own sanitizers, and they sit down in a waiting room, and you can watch people. If you're in a waiting room, they pull out and they open up their alcohol wipe and they start wiping down the chair they're sitting on, or they start wiping down the what they've got in the room that they're in. So as a result, I think there's a demand now for more chemically resistant materials and materials that stand up to that level of abuse. And whether that goes away as soon as COVID disappears and there's a vaccine out and it's widely effective and distributed, I don't know. I imagine it won't go away completely, that people are still going to keep some of these behaviors because it makes them feel safe. The second trend that we see is antimicrobials. And it's a trend that I don't think has penetrated very far into the healthcare community, but we've certainly been asked about it a lot and we've heard about it a lot. So antimicrobials are materials that have additives that have some active agent that leaches out to the surface over time, and it can interrupt the metabolism or the cell structure of a pathogen. So some people have looked at this as, oh, hey, COVID and this seems to fit. But some things to consider is when you use an antimicrobial material, the surface still needs to be clean. So using those kinds of materials do not get you away from cleaning and disinfecting. You still have to do that, so you can't let it lull you into a false sense of security. Second is as these active materials are coming out of the material, there's a finite lifetime because there's only so much material that can leach out. So it's not a decades-long solution. Third, we don't really know the long-term toxicity of all of these different additives. And fourth is pathogens can develop immunity. And we've seen that. So silver ions are commonly used as antimicrobial materials. And we've already seen some bacteria develop resistance to silver ions. So our position is that cleaning and disinfecting is still the way to go. And that's likely to continue even after COVID for those reasons.
Mike, are you seeing that, just before you go, Mai, sorry, that these kinds of surfaces that are prevalent in healthcare settings are now extending into commercial office settings as well as our administrative settings?
Absolutely. So that's a very good question. We have seen that in a lot of other industries, people are taking the lead of healthcare. So they're looking to this kind of community to see, well, what is healthcare doing? So for example, in hospitality, hotels are looking to healthcare facilities and understanding how they manage their spaces and trying to learn from it. And we have heard antimicrobial materials pop up more outside of healthcare as things that people have ideas about or are interested in. So we answer a lot of questions about antimicrobial materials.
I would like to comment on the antimicrobials from a Scandinavian perspective. In Denmark, the Danish Serum Institute has banned every product for healthcare use because we're so afraid of superbugs. We are so afraid of that we cannot control the environment, exactly as you said, Mike. So there is no business for that in Scandinavia right now. Also, I'd like to comment on your perspective, Margie, around the waiting rooms. From an acoustics point of view, this is actually a good thing that we don't have a lot of people in the waiting rooms because they are often really complex facilities in regards to sound, because we have a lot of sound sources in these open environments, and often that particular environment is not prioritized in regards to hygiene and disinfection and cleaning. Actually, when you come into a waiting room today, you can go very far by selling an acoustic product that is just an office product, because before COVID, the trend was, as you access a hospital, when you go into the patient wards, you move on further to the ICU or operation theaters, you will have more demands on acoustics and on hygiene. So the waiting room will often be an office product, and that will not take care of the sound environment that is really complex with a lot of sound sources at the same time, and it will not at all take care of the hygienic issues. So I think that we will see a change there, that we will no longer see just another painted surface in the ceiling that could fit into an office situation. I think that we will see in the waiting room that people will come back and we will level up the acoustics, because we know it's a complex situation with a lot of sound sources, and now we have learned that we need to take care of a pandemic situation if it hits. So I think that we will see some changes in the open space. I see, of course, off-site construction modules popping up everywhere to take care of the extra people. But I think that we will have people coming back into the natural situations again, and we will simply level up the surfaces.
Yeah, and I do see too in waiting rooms that we're being requested to have more segregated sick and well space. And so, whereas before I was saying that everything was so open and airy, and now it seems like we're really starting to segment spaces and to separate people. And then also, it's so interesting, even furniture now you're seeing a lot of designs coming out where you have complete enclosure over a seating grouping or just a seat itself. And, when they first came out, I had my doubts about how well that would be embraced by the design community, but now it makes perfect sense, and it's a pretty fast solution in this time of COVID.
You also mentioned staff facilities, that where should staff go to relax when they have had a really hard day, and that was a problem even before Corona.
Right.
That staff rooms were often under prioritized, where you should go and have a nice time with your colleagues. It was just the worst room at the floor where the nurses could sit and have a chat. So often what we work with right now at Echophone is actually to do something about the sound in these facilities, because you go to relax, you go to maybe have a nice time with your colleagues, but it's impossible because of the physical environment. So I think that we will also, hopefully, this awful situation that we realize right now will stress that the staff needs a nice place to go and relax just for half an hour during the day.
Absolutely.
I think a lot of this speaks to having the right partners at the table is earlier in the design process. I think that oftentimes, I don't know if it's in Europe the same, but in the US, the acousticians or the people who are studying that are sort of on the side or come in too late. And so what's happened during COVID is that we've had to pivot so quickly. And the only way to do that is to bring everybody to the table from the start, which has not been a popular way of sort of doing construction projects and design projects. But it is something that I personally am very passionate about, because it's a sort of a lean mentality where you know, the end user doesn't have all the problems that the rest of the design team just didn't focus on. So where we had the U.S. Army Corps of Engineers come in and ask us to do field hospitals, and they just said, it's just good enough, just make it good enough. We're going to have to figure out how to move on from that. But I think that owners in this role, the trend is that they've actually experienced what this sort of integrated design process and construction process could look like when you have a driver of, you know, you need to get this out and you need to be able to serve people so that you can save lives. So that's actually a trend out of this very unfortunate that I would never wish, no one would wish on anybody. That's one of the sort of positive things that has come out as a trend. And I think sort of our last focus is about flexibility, is just that. Mai, did you want to ask your question about flexibility?
Yes, we see in Europe that over the last decade, the only country that has had an increase in patient beds has been Germany. The rest of the countries have seen a decrease. And the reason why Germany's have more beds now is that they were on a really low level. So what we expect to see in Europe is more flexible hospitals. We will not see more patient beds. We will not see bigger facilities, but we will see more flexible units. For instance, if you have an elderly care unit in a hospital, it should be possible to transfer it into an ICU or the other way around. And I would very much like to hear your views on the flexibility as part of a sustainable and resilient healthcare facility.
Well, I think you've hit on a really good point there, and that's something that we're considering in projects going forward, and even in some that were in design already, is that how do we make patient care units that have the adaptability to deal with different patient populations based on grouping like diseases together. You know, at the University of Michigan, we had a project that's going on, and they immediately wanted to change some of the floors to become a regional infectious care unit. And what that means is that you have, it's not room by room that you can control the airflow, but it's unit by unit. And so some units can be turned to negative pressure entirely to allow to have some of that kind of activity happen in there without having to try and build all these field hospitals. I think that's been one of the big lessons that we've learned, is that, you know, in order to really be able to treat patients, you know, there's the two things you need. The first thing you need is the right kind of staff, and that's been a real challenge, and we've talked about that some. But then the other is to have spaces where people feel safe and are able to get some confidence that they're not going to be exposed to other diseases while they're in the hospital. And we've talked a lot about hospital-acquired infections.
Right.
That's something that's always been a problem, but now I think we'll be able to take it on a little more strategically and think about whether we put extra gases in some patient rooms, you know, how do we deal with the need to be able to isolate different sections. So I think all of that is starting to work into the way that we're planning and designing projects now.
Just another question to that, Paul. Here in Scandinavia, we see a lot of outpatient clinics as well. And we have seen here during the pandemic that they have been also included into the pandemic situation, actually meaning that people who are normally in an outpatient clinic will have telehealth, so we can use the facility. So it's not only a hospital, but also clinics that have to be flexible. What are your thoughts about that?
Yeah.
Oh, I think there's a lot there, and I think that one of the things that's going to be very necessary for that to work is the topic that you have been talking about, is the room acoustics, so that providers can have a private place to go and do a telehealth consultation in the middle of a clinic day. You know, that it's sort of been kind of haphazard, and they go back to their office, or they do it after hours. But I think it needs to be integrated into the whole clinic process. And to do that, you're going to need to have really good acoustic isolation for those rooms where those conversations are going on. We already had it for HIPAA. You know, it's already been something that we've been discussing for a long time with room-to-room transmission. But now being able to have, as you were talking about, the really good in-room acoustics to be able to have the discussions that that allow people to feel comfortable getting their care.
Actually, also knowing that most patients are elderly people. We grow older as a race because of demographic changes, and that means that a lot of us will have hearing impairment simply because of age. So we will be really vulnerable to discussions that are not coming through clearly. And I don't know what it's like in the US, but here in Scandinavia, we don't dare to speak up to authority. So if a doctor tells my old mom something and she doesn't really hear it very well, she will not ask again, what did you say? I'm sorry, I couldn't hear it. She would just say yes, yes, and she might not get the information. So I think that we have a good business opportunity. We have something that we really have to work hard on. Sometimes you can fix it with a nice headset, but sometimes the facilities also have to be updated.
And you know, May, I design for senior living as well, and so acoustics is a big issue because with the hearing loss comes hearing aids, and it's something that if there is a lot of background noise or you know, the sound just is just bouncing off the surfaces in that environment, it actually becomes deafening in that they can't hear beyond that. And so it really is just a science trying to get that balance. It's so very important. And, you know, the other thing that I wanted to bring up in an inpatient setting, acoustics actually is one of those things that is monitored for patient satisfaction in the HCAHPS scores. So, you know, it's something that our clients are demanding, and you know, we need to respond in like kind.
I would like to have such a system here in Denmark. It sounds really, really good. We have public welfare, healthcare. So we have some other issues. So the hospital can you wouldn't know who to complain to if you weren't satisfied with the sound in the public hospital, because you go there for free. And so it's another discussion, but I would really love like an emoji thing that you could push when you left the hospital. How satisfied are you with 3 things? and the physical environment could be one of them. I really think that it could be beneficial for our end users, because we know that light, air, and sound will affect the patients as well as the staff. And if we don't if we don't do it right from the beginning, we will have issues, and we will see more healthcare acquired infections. Actually, we will see more burnout, and we can do it right, but we also need the feedback from the end users. And I would really love such a system in Scandinavia.
And perhaps if we engage the right people early on, it won't have a really great impact cost-wise if we can do things smartly and strategically, right? Mm-hmm. I'm interested to know about this idea of flexibility and ability to pivot, and how sort of the mergers and acquisitions of larger health systems were able to maybe pivot quicker or react better. Margi, can you talk about your experience with that?
Yeah, excuse me, my earbud just fell out. Yeah, we did something really interesting this past July. We had these coffee chats, 3 one-hour sessions with several groups of our academic medical center clients. And it was fascinating, the information that we received from them. But it was really more of a conversation, and we were peering in on it. We teed up one conversation, how have you responded to the COVID pandemic? And taking all this in, and just categorizing. There were about 5 buckets, if you will, that seem to have common threads or common denominators. And the one thing was this notion of systemness. And I was really surprised by it because, we know that all of our academic clients are fairly sophisticated, but, it seemed to me that they felt that they came together more so because of the pandemic, and really functioned on a very physical level, more closely and more as a system because of the pandemic. So it was actually a good outcome for them. And the one area that I thought was interesting was supply chain. There were a few that mentioned that their individual facilities were operating fairly independently, and because of the pandemic and the scarcity of materials, whether it be PPE or ventilators, they decided that they really had to consolidate and have a centralized supply chain distribution center. And so, what an interesting opportunity for planning in the future to really get ahead of something. So that was one of my bigger takeaways, believe it or not, for an interior designer, supply chain.
And I think it's really fascinating to understand what goes on for owners, so that somehow we can benefit from that in our design process and also our construction delivery. One thing that I noticed as a trend early on during the pandemic, we were asked as modular construction providers, how fast can you do something? Is it already an off the shelf? And really, a lot of us didn't have something off the shelf. But at Boldt, there was something that was in under development. So it was already sort of halfway there. And with this need to surge and flex and sort of pull all your, sort of level up your med-surg beds to make them ICU beds, there was just a gap of observation beds. And so we were able to deliver a 16-bed unit somewhere in Georgia within a few months' time. And then that health system, because they were connected, said, well, hey, if you could solve for this, you can solve for this other area that we had. So actually, I mean, it's terribly fascinating that they were able to deliver 71 beds. The inception of this idea started in July, and the last patient bed was available by December. So 71 beds, I mean, it's really unheard of. So the only way that was able to happen was, the modular delivery, but also to have, everybody at the table, a very integrated approach and compressed conversations to share how everybody could rework how they understand construction and sort of twist it a little bit to deliver more quickly with a high quality product. You know, SGI is actually responding and reacting to COVID. They had to put something out to say like, this is good enough, but what are we going to do? You know, if the next pandemic comes around, we will be much better prepared and we'll understand what sort of level, quality, and code compliance we're going to need to deliver. So we're actually, any other remarks on space use and shifting around for that?
You know, just this whole notion of flexibility, I mean, there's no question it's here to stay. That was another big takeaway from the coffee chats. And in fact, you know, we're doing projects in a very big way with modular components and even demountable interior partitions for medical office buildings. And you know, it's really fascinating to see that industry emerge. It's been around for a while, but it's really starting to explode now. And more clients are asking about that, and they just want that flexibility.
And so to clarify for the group, demountable walls doesn't necessarily mean that you're building something and then you're going to take the walls down or move them around, but they're actually sort of prefabricated wall systems. Mm-hmm. And you can approach them as a very sort of simple, let's just build the drywall and let's paint dry here and then put that up. Or you could do a completely panelized system full with mechanical, electrical, plumbing all ready to go and just plug and play. So we have come quite a long way. And I think people don't realize that you're seeing modular systems everywhere. It's right. Just we're sort of expanding that understanding.
Right.
We also see more and more modular systems and more off-site constructions in Europe. The only problem we see in regards to that within the field of acoustics is that not all producers, not all manufacturers know about acoustic standards. So you can actually buy an operation module, a theater in Germany, and put it into a hospital in Sweden, and then it doesn't comply with the standards. So we see a lot of money is saved when we do these modular constructions, but we see a lot of issues. So we have to work on the modules afterwards, even when the hospital is built. So it's really difficult for now in Europe to make sure that the manufacturers actually know about the standards, because we have a lot of standards, building regulations that are different from country to country. Even within Scandinavia, we don't have the same standards. So that is something we can also be better at.
This idea of leveling up actually applies, I think, to that, because we really want to have a one-size-fits-all approach. And even so, then in the US, there are earthquake zones, there's hurricane zones, there's snow zones. Do you really want to provide a one-size-fits-all for the, you know, the avalanche that might happen on the border of Canada? For everything, probably not. But as long as we're intentional and we're able to have those conversations early, then we'll understand the context where we can provide that kind of solution. I just want to also mention, because I know that Europe is way farther advanced than the US in modular, particularly when it comes to residential. And I think that, you know, I was scratching my head about why California, why were they suffering so badly when the rest of the country was kind of like leveling off or moderating? And I really believe it's because the cost of housing is just insane. And so people have resolved that by having 8 to 12 people, familial relationships in a room. And these are people who have like white collar jobs and, you know, make a reasonable living, but they're packed together like sardines because of their housing situation. And that's sort of, there's some studies that are coming out that are showing that that's why they were really hit hard by COVID, harder than some other areas. So, so being able to expand with modular housing, affordable housing, truly affordable, would be a great outcome. Mai? Okay, I interrupted you, so I didn't want to interrupt that thought.
Oh, no, it's fine. Let's move on. Okay. It's fine.
Well, So we're actually nearing the end of this panel, and we wanted to carve out the last 10 minutes to just have our end remarks, so what we want to leave the group with, and it's sort of centering around refocusing on sort of what we need to pay attention to that we might have been neglecting during COVID. So in no particular order, but I'll shoot it to you, Mai.
Thank you. I once had a meeting with an architect from the Netherlands, and she was trying to work with room acoustics in hospitals. And she looked at me and she said, "Come on, you guys, we can travel to the moon. We can fix this." And it was just such a good picture of, yes, we can actually fix good room acoustics. And with COVID coming, we can also fix the hygienic issues. I think that we have had a tradition within the acoustics world with a lot of perforated plasterboards maybe, or
Did
we lose your audio?
I think that there's a strange irony in her being an acoustics person and so, but maybe we'll come back to Mai-Britt. Thank you, though. Why don't we just go down the line to Mike? Thanks.
Yeah, so I'll continue. You were talking a little bit about hygienic materials. I think we've seen a lot of acceleration of trends that were already in motion because of COVID, and hygienic materials is certainly one of those. I think there's been a lot of changes in behaviors and facilities needs that we'll have to ask the question of, are these going to stick around? And some of these changes have been quite good. So the work from home trend, having more flexibility for staff to not use the facility, but to use their home office. The increased cleaning certainly makes me feel better. And people cleaning on their own. So are these trends going to stick around, or will they suddenly go away when there's a viable vaccine? I don't really know the answer. But from a design point of view, I think we ought to design for longevity and design for the worst case, and make sure that our facilities can last no matter what happens. And even if there's another pandemic, to make sure that we've learned lessons and we're better able to handle the next one.
I think
Paul?
I'm next. Oh, I'm
Okay,
sorry.
go ahead, Margi.
I didn't know if we were going down on my screen. Yeah, I think now that we're finally, well, let's hope we're in the final stretch of this and we're getting out of triage mode. How's that in hospital terms? I think that what we're going to be doing a lot of is helping our clients to really find balance. So, you know, we talked about telehealth. One of our clients in specific, pre-COVID, they had 10% telehealth usage. At its peak during COVID, they were at 85%. Now, they realize that it's not going to stay that way, but, you know, when the pendulum swings to the middle, where will that be, and how will that impact how much space they really need? And as Paul had mentioned earlier, I mean, we've had a few projects pause and rethink space needs based on telehealth. So, but you know, that's just one example. But I think that really finding that balance once we really get past this.
Okay, so the thing that is sort of a continuing theme in what we've been seeing for trends in future is really the move away from an episodic care model into something that's much more wellness based. Telemedicine will contribute to that a lot. Just by keeping people out of spaces. You know, one of the effects of all this isolating is that people haven't gotten sick with colds and things like that because they've been able to stay apart. I think that would continue to be effective by people being able to engage their care providers a lot less often in physical space and a lot more often digitally, so that they can head things off before they get to be serious. and that will help us as we sort of look into the future about what do we really want to pay for in healthcare, and how do we want our economy to adapt to that. So learning those lessons and applying them well to outpatient, particularly cohorts, will really make for a big change in the future.
And I'll end with, I think that we've learned how to be wildly collaborative in this process to pivot. That actually terrifies me and it emboldens me at the same time. But the reason being because when owners come and see us turn around things very quickly, I had a project, an Ebola unit that needed to just be contained in 2 days. So basically in 72 hours, we modified a part of a unit to become Ebola sort of compliant. And before we occupied that, I said, I want you to forget this ever happened because nothing happens this quickly. But I do believe that one of the lessons we can learn from this is that we can actually compress the schedule, and we can make early decisions if we have the right people in the room in an integrated way. And I keep on hearing more space, more space, more space. But if we're strategic, it doesn't have to be expensive. And I think so that I think is a potential hurdle in thinking and mindset from an owner perspective but that we could solve as a design community. So we do have some questions in the chat, and our facilitators have kindly numbered them. So I'm just going to actually go down the list. The first question that we have is, what do you think about using nanotechnological materials in healthcare design, meaning antibacterial surfaces, self-cleaning coatings? So I'm pretty sure this goes to Mike.
Yep, I'll take that one. So I find nanotechnology very interesting, and I love reading about all the advancements that are made in that field. Now, applied to healthcare, I think we need to be a little careful with nanotechnology. Because these are very small materials that are now going to be a lot more bioavailable. So we have to be very, very careful with how we're using them and their toxicity, not just acute, but also long-term toxicity. So we really need to understand them. And the second thing to note is these are additives that are included in materials. They still have to have very good contact with something on the surface. So your surface still has to be clean. So all of these materials still don't get you around having to have someone go through and clean your facility. So proceed with caution.
So if you don't mind, Mike, can you just explain what nanotechnological surfaces are?
Yeah, so nanotechnology is any material that has a dimension typically under 100 nanometers. And what that gives you, materials just have some pretty unique properties when they're down in that range. First, because you have very high surface to volume ratio, so you have a lot of surface available. So if you have some mechanism that acts on the surface, you've got a whole lot of surface to play with. And the second is you can get some interesting electronic modifications in materials down at those size scales, which can affect, like if light shines on it, it can generate high energy electrons, which can then go and break down or decompose some organic species on the surface. But again, that decomposed species is still going to sit on the surface until you clean it off.
Thank you for explaining that. Very good. So the next question, can you please elaborate on health providers learning from high performance athletes? Can you please give specific examples? This one's for Paul.
Yes, thank you. Sounds like an SAT question, but it actually is a pretty exciting thing that we've been learning as we've gotten into these kind of hybrid projects. It started with Emory Sports Medicine teaming up with the Atlanta Hawks to form a sports medicine clinic that was attached to the Atlanta Hawks training facility. As part of that, they included a motion analysis lab. And the reason they do that is that they can actually engage in, and some people who are in this world talk about this, prehab, meaning that they're able to anticipate injuries and fix them before they become a problem. And the example was in this lab that we had been working with, they had taken a a young athlete who had an injury in college, was about to be drafted, and I think it was by the Hawks, but I can't say. And they needed to find out if he was really healed or not. So they ran him through the motion analysis, which you guys probably have seen with the dots attached to your joints and cameras from all angles and force plates in the floor, to examine the way that this kid jumped and landed. And what they realized is he had fixed the left knee, but as he was fixing it, he'd started landing harder on the right knee. So in order to prevent them from making $1 million mistake, they prehab that knee. Now they take those data that they collect in the motion analysis lab, they make it anonymous, and they feed it over to Emory University, who then go through research trials to be able to understand what the kind of outcomes could be, and how they might be able to develop new prehab regimens to be able to keep people from getting hurt. So there's a lot there. You know, I often liken it to the relationship between the F1 cars and your own car. So Mercedes drives a bunch of race cars around a track. They find out what the best performance could be, and then they bring those ideas into your car so that they're safer and faster and more fuel efficient. So same thing. Top created athletes become testing grounds or testing for understanding to be able to apply to everybody else. So everybody has access to that kind of treatment and cure.
It also sounds like a logical extension of, I think, what's been happening pre-surgery. I tore my ACL 5 weeks before my wedding, and I did some prehab, I believe, prior to surgery so that my recovery would be quicker. So I believe that that's sort of a trend that's growing, and that's really fascinating. Okay, so how much space do you feel these new staff areas might need? Sounds like a Margie question.
Well, that depends on who you ask. I mean, obviously, staff will want more, you know, and then juggling it with available space in an existing facility. That's always tough. It's a little bit easier in a new build, and you can program that into the project. But you know, I think that we do have to be realistic that you know, these spaces are probably not going to quadruple in size, but I would think, you know, it just depends, because you've got clinics where you have small staff lounges, and but I think maybe speaking from a percentage standpoint, potentially maybe sometimes even 1.5 times the size, you know, because what we're finding too is in these staff lounges, you're even putting together telehealth booths or rooms where providers can, and not so much in a staff lounge, but more in a physician or provider lounge, you're providing for that space. So it really just depends on what's programmed into that space. But I think that that health systems need to be more realistic about, you know, not just taking the leftover space, but really programming the space, and they are. I mean, there's just been a great deal of compassion and empathy, and I think it's wonderful.
It sounds like just being more intentional from the planning perspective, definitely
Right.
not leftover space, but also considering, are they the providers or are they also your EVS workers? I mean, they're going somewhere else to decompress, and how much of that should be considered.
Exactly.
Okay, so another question is, from the standpoint of resiliency, having the ability within the facility to convert healthcare spaces also affects the type and number of elevators, the logistical question, necessary to support these spaces. How are these being included in new hospital design?
Is that one for me? Probably
Sure.
is. Yeah, the nice thing about hospital elevators for the most part is that in inpatient settings, they're always over elevated, or they should be, just because 2 is better than more than twice as good as 1, and then having separation for clean and dirty and staff and public and patient all drives the number of elevators up. I think though that one of the things that we've seen, and we've talked about this a number of times on the really high intensity infectious disease units, is having a direct path to an elevator to a location where they can stay isolated the whole way. I think that may become a more critical kind of design idea, in that the path for a patient, we always think about the way the patients come in, and most of them come through the emergency department, but there's going to need to be a short circuit out of the emergency department directly to the infectious care unit, whether that's on the ground floor or on another floor, because they've made an adaptation. They need to be able to identify which elevator was going to do that, and I think that'll happen. I think that part of the codes for healthcare have some of that baked in, but as we look at post-COVID, we're going to be looking at those kinds of design innovations.
And I think that you're sort of looking at it as almost like a code blue event, where you can override elevators and make sure that there's no one else, empty them out and that kind of thing. So it's an emergency response. Okay. Any comments on that, Margie? Good. Okay. So the next question, actually might be for Margie. With respect to senior living facilities, which now require larger clearances for the larger size wheelchairs for compliance with ADA, why weren't the larger wheelchair requirements carried over to the elevator system?
I saw that question, and I'm not entirely sure that I can answer that, really. Yeah.
I mean, I think that elevator design, I think that in another life I would have gone into elevators, because it's a really, there's not a lot of those companies, and they're very well, I don't know, featured, but I think it's just harder to move the needle on that. They've been designed around this sort of standard for so long, but perhaps that's something that we should bring to their attention.
Yeah.
Paul, did you have a comment on that?
No, thanks.
Okay, we'll sidebar that with like Otis or Schindler. Okay, so
I think VDA may be on the call. I don't know. Some elevator vendor may be on the call.
Oh, great. Yeah, that's true. Okay, next question is, do you see the use of controlled and managed daylighting within these designs as key to employee and patient health with other benefits?
Yeah, absolutely. Because now we're talking wellness, and honestly, that is where everything is going. Health and wellness. It's not just reacting, but rather preempting. And I think evidence-based design has proven that daylight, views to nature, some of the biophilic design principles, these all contribute to health and well-being. So, whether it's employee well-being or patient health, just fascinating. And, I really embrace it, and I'm excited to see this industry explode.
So I think that brings us to the end, and I think that's a great way to stop end this conversation, to talk about all of our wellness, and that we see the light at the end of the tunnel, and we're going to run towards it like the Dickens. So thank you for joining us and sharing all your thoughts and insights, and thank you to Midwest Build Week. Have a great week.
Thanks,
everyone.
Thank you, everyone.
Take care. Be
well. Thank you to all of our speakers, and a big thank you to everyone who has joined us in the audience for this session. Our next webinar will take place shortly at 3:30 p.m. CST. This panel discussion is titled Built to Last, Unlock Your Potential in Future Construction Projects. You can sign up to join this session via our website at www.midwestbuildweekonline.com. We hope to see you there. Thank you.
Thank you.